from bacterial infection. Resulting from bacterial infection. Acute cystitis. This is inflammatory disease of the bladder of bacterial origin. Exists such term like chronic pyelonephritis, kidney damage manifested by fibrosis and deformation of capillars plating system as a result of repeated attacks of infection. What it means, chronic pyelonephritis. What is reflux? Reflux occurs rather frequently among children, and it means focal or diffuse sclerosis of the renal parenchyma, which is the primary cause of vesicular uretral reflux, leading to intrarenal reflux, repeated attacks of pyelonephritis, and renal tissue hardening. And another term is urosepsis. This is generalized non-specific infectious disease that develops as a result of penetration of the urinary tract in the bloodstream of various microorganisms and their toxins. If we shall speak about etiology and pathogenesis, we may say with sure that the prominent occur gram-negative flora occur 90% of all cases belong to Escherichia coli infection. Gram-positive microorganisms may cause UTI like enterococci and staphylococci. Sometimes Klebsiella, Pseudomonas. In some children, we can see resistance to antibiotic therapy because microflora is very strong and very resistant to the action of routine antibiotics, and sometimes it's necessary to give serious groups of antibiotics. As for predisposing factors of UTI, here is different congenital abnormalities of development of kidneys, obstructive uropathy, vesicular uretral reflux, neurogenic dysfunction of the bladder. Neurogenic dysfunction of bladder may be two types. Maybe with hypofunction of maybe with hypofunction, and maybe with hyperfunction. Hypofunction means when will be very rarely urination, and hyperfunction means very frequent urination with small portions. The most common way of infection is considered to be ascending route. A reservoir of uropathogenic bacteria are the rectum, perineum, and lower urinary tract. And maybe several routes of entering infection to organisms, like ascending route, lymphogenous route, and hematogenous route. Features of female urinary tract, like short wide urethra, the proximity of the anorectal region contribute to greater frequency of occurrence and the recurrence of urinary tract infections in girls and women. Sometimes parasites, poor hygiene in girls, and frequent urination and bad toilet also of genitalia, leads to development of UTI among children. Hematogenous route occur rarely in children. Sometimes also maybe may occur such infection like actinomyces, brucella, and Mycobacterium tuberculosis. The prevalence of urinary tract infection in children is about 18 cases per 1,000 of all child population. Of course, incidence of urinary tract infections varies with age and gender. In severe cases and general character of complaints occur among young children whose age is below 1 year, and up to 3 months of age. Urinary tract infections more common in boys, and in older age in girls. The relative risk of relapse increases with age after the first transferred episode of UTI. The recurrence rate, girls, (30% episode within 5 years after the first episode. Boys, 15 to 20% within first year after the first episode. How we can classify UTI? Here you see classification coding, maybe non-obstructive chronic pyelonephritis associated with reflux, chronic obstructive pyelonephritis, other chronic tubular interstitial nephritis, chronic tubular interstitial nephritis unspecified, abscess of kidney and perineal tissue, acute cystitis, interstitial cystitis, and urinary tract infection without established localization. As for classification, the presence of structural anomalies of the urinary tract system. Localization may be pyelonephritis when will be damage of renal parenchyma and pelvis, cystitis when will be involvement of bladder, and urinary tract infection without localization. Maybe according to the stage, maybe active stage and maybe remission. Chronic pyelonephritis may be with exacerbation period and maybe with period of remission. What will be character of complaints? The smaller child, the more general will be character of complaints. For example, in small children will be vomiting, fever, even febrile fever. In old children, absence of catarrhal symptoms, abdominal pain, dysuria, sometimes flank or back pain, Sometimes maybe suprapubic pain with irradiation to genitalia. And urgency, frequency, even till enuresis. In physical examination, we pay attention at first on the color of skin. Skin is pale. In patient will present tachycardia, sometimes symptoms of dehydration. A sharp smell of urine. In acute pyelonephritis will be positive Pasternatsky symptom. Pain when we make beating, or have small children when we pressed with your finger between the base of the 12th rib and the spine. Patient feel the pain. Will be determination of bacteria, leukocyturia, in general analysis of urine. Also presence of erythrocyturia. What we should do else? We should determine level of C-reactive protein, because this is the most important protein in all diseases with inflammation. Especially if presents fever more than 38 during several days. Leukocytes will be high level of C-reactive protein. If amount of leukocytes is greater than 25 in 1 milliliter, or more than 10 to 15 in the visual field, the diagnosis of urinary tract infection is the most likely. It is recommended to consider isolated pyuria, bacteriuria, or positive nitrite test in children whose age is below 6 months and present signs of UTI. Also, we check biochemical analysis like urea, creatinine, and such analysis may give us information about function of kidney, function of filtration. In this table, you can see differential diagnostic criteria for acute cystitis and acute pyelonephritis. As we see, in cystitis, fever is non-typical if to compare with pyelonephritis. Symptoms of intoxication occur rarely, very frequently present dysuria in patients. SR not changed. Absence of proteinuria, may present hematuria, because in UTI, salts exist, oxalaturia, phosphaturia, oraturia, and salts has different size and shape and may cause mechanical trauma of ureter. That's why present hematuria. Leukocyturia. Kidney concentration function usually is normal. Enlargement of kidneys on ultrasound usually is normal. If we see pyelonephritis, here present fever, pain, leukocytosis, hematuria is non-typical, kidney concentration function will suffer, will be lower than usually. Enlargement of kidneys may present. It's recommended to carry out ultrasonography. Ultrasound is the most available method for us. On the second place is voiding cystoretrography, intravenous urography, and then if we shall not find any reasons, we check, we make, we send the patient to the capital of our country, to the nephrologist, to exclude some pathological conditions which we don't know. We send such patients to Moscow. Because ultrasound can give us only small, or only very poor picture of UTI. It may show us stones, dilatation of pelvis, but hydronephrotic transformation is not seen on ultrasound. Sorry, presentation. Recommended voiding cystoretrography to detect reflux in patients. Different congenital anomalies like posterior valve of uretra. In children with first-degree episodes of urinary tract infection, cystoretrography reveals vesicular uretral reflux of third to fifth degrees. Only in 17% of cases, first to second, 22. And other children has no any changes on ultrasound. Indications for cystography. Children up to 2 years after an episode of febrile urinary tract infection in the presence. Changes of kidneys on ultrasound, enlarged kidneys, dilatation of pelvis, recurrent attacks of UTI. Static nephroscintigraphy is recommended to the patients with chronic kidney pathology not earlier than 6 months after the acute episode. Indications if patient during 1 year of life had 3 documented cases of UTI. As for treatment of UTI, in this picture, you can see that the drugs of the first choice are antibiotics, but antibiotics are better to give in tablets, not intramuscular or intravenous injections. Only if we have severe cases, we give a drug in injections. The drugs of the first choice are amoxicillin, 50 milligrams per kilogram per day, twice per day. Cefixime, 8 milligrams per kilogram per day, twice. Cefuroxime, 50 to 75 milligrams per kilogram per day. Ceftibutin, 9 milligram per kilogram per day, once per day. Then another group of drugs are uraseptics like cotrimoxazole, furazidine. Cotrimoxazole is given 10 milligrams per kilogram per day, 2 to 4 times per day. And furazidine, 3 to 5 milligram per kilogram per day, 3 to 4 times a day. When prescribing antibacterial drugs, it is recommended to make sensitivity for microorganisms. But of course, sometimes when we can receive this analysis in several days. And what to do in such cases when we have no time to wait? Here we give such antibiotics of wide spectrum, which may action on several microorganisms. In case of vesiculorectal reflux and recurrent UTI, long-term antibacterial therapy like prophylaxis is recommended. And here about 3 to 12 months. It is recommended to control the regularity of bowel movements to prevent lymphogenous infection. Recommended dose reduction of antibacterial drugs depending on creatinine clearance test. Sometimes for children it's very difficult to give drug through mouth, by mouth. In such cases, we look for another ways. But in any case, we recommend to change antibiotics to treat till full remission. As for parenteral drugs, we give aminoglycosides, amikacin, once time per day. Dose of intramuscular antibiotics is about 70 to 100 milligrams per kilogram per day. And how many times? 1 to 2 times per day. To whom recommended prevention? For patient after operation, for patient who had very frequency attacks of UTI in anamnesis, and here exist such doses. Furazidine, 1 milligram per kilogram per day, once at night. cotrimoxazole 2 milligrams per kilogram according to sulfamethoxazole once at night. In general, I wanted to say that results for treatment of UTI are very favorable, rather favorable. How many years I work, I never seen complications of UTI when it's present, when it lead to renal failure. Very, very seldom. Of course, the earlier we shall detect vesiculolateral reflux, the better will be prognosis, because usually without looking that after operation, all patients have asymptomatic bacteriuria during long period of time, and during long period of time they need to receive antibiotics. In future results are rather favorable. I know a lot of patients who were treated in Moscow, in Respublikanskaya Children Hospital. And sometimes in patients receive arterial hypertension as a result of reflux nephropathy, especially in pubertate period. That's why we should treat all these complications in time to prevent relapse. And usually we for prevention we give antibiotics, for example, during long course 10 days, then stop therapy and give half or 1/3 of initial dose on the long period of time, about 3 months, to prevent relapse. All people who had operation, they admit then they come to the doctor or admitted to the hospital with asymptomatic bacteriuria. This is always in patients with pyelonephritis, secondary pyelonephritis. But the results are very good, and in several years we can speak with parents about full recovery. That's all. What questions do you have to me, doctors? Have you any questions to me? If no questions, I wish you a good celebration. I wish you to be healthy without looking all our situation. And I hope that everything will be okay. Thank you for your attention. Goodbye.